This one, the podium, yes. Hello, everyone. It's really great to see so many people here for the summit. Thank you for coming. We're going to get started, and feel free also to still get breakfast, coffee, anything that you want. It's okay to get up and get it during the time. I am Cheryl Dixon. I am the Associate Dean for Health Equity and the Chief Diversity Officer for WMed, and I'm really happy to welcome you to our annual Health Equity Summit. This was a planning collaborative with Western, with Dr. Candy McCurkle from WMU, K College, Brian Dietz. I don't know if Brian is here. K. And KVCC, Trice Batson, if Trice is here. Hey, Trice. And I'd like to thank, again, up front early, all of those who have helped to make this event possible today, especially the program specialists I have for health equity and community affairs, Tanya Mitchell in the back. She's the one who set up these lovely tables and really organized this to the max. Also, Laura Counterman from Facilities. Amazing. Thank you, Laura. All of the CME staff, I don't know if any of them are here, but the CME staff, as well as all the volunteers that you're seeing at different tables that have been helping us throughout the day to actually help to make this possible. And I also want to have a special thanks to Dr. Akush. Dr. Akush, can you stand? Thank you, Dr. Akush. He helped us really with our posters and organizing for actually having, and please, that's part of this summit is we have posters. We really want you to visit those posters. Lots of our students have posters, and it would really be great for you all to take time to look at the posters. So this year's summit, as you see, is focused on women's health equity. And the Health Equity Conference that we're having today, we're hoping to raise your awareness, provide education, and encourage conversation around the importance of health equity, cultural competency, and well-being for women in our healthcare system and in our medical school communities. As a medical school, WMed is focused and committed to health equity as our core strategy and our goal, which you'll hear more about from Dean Termulin when she speaks, of what we want to be and what our goal is going to be. Our values are embedded in having a just culture for belonging, with diversity, equity, and inclusion as central tenets, with an authentic collaboration with the community. So I'm really glad that a lot of community members here. Thank you so much for coming. We could not do this work without you, and we need to work with you to do this work. And as most of you are aware, equity is about giving people what they need, right, to attain the best health outcome possible. And I want to emphasize giving people what they need. And that means that we have to understand that some people need more or need something different in order to be able to get the best healthcare outcome. There are persons that are underserved, that have been marginalized due to their race, their gender, their religion, their ability level, their experience with greater disparities in health outcomes. And so we want to achieve equity for all of them. And so what does that mean? We also have to be informed, like this conference today. We have to be informed about the root causes of what we're seeing in those disparities. And we have to commit ourselves to not just individual work, but to systemic and structural changes in our institutions and in our policies, and as well as in our individual practices in order to achieve that goal. To that end, I'm really honored, and we are honored here at WMed, to have distinguished speakers and workshop presenters here for this summit who've come from various other places, from North Carolina, South Carolina, from Maryland, from Pittsburgh, to actually add to our collective knowledge of health equity needs and programs for women. We are glad that you're here, and really hope that you'll be able to attend as many of the workshops that you can, because we have some excellent presenters. And again, I'm going to emphasize to be sure to visit the posters. Now it's my pleasure to introduce our dean, Dr. Paula Termulin, who's going to formally open this up. Let's tell you a little bit about Dr. Termulin first. She's our dean. She's a professor of surgery here. She's also board certified in surgical oncology and has specialized in breast surgery. She's widely published in surgical oncology and surgical education. She is the past president for the Association of Program Directors in Surgery and an inaugural member of the Academy of Master Surgeon Educators. Additionally, she served a variety of roles for the American College of Surgeons, Association of American Medical Colleges, Accreditation Council for Graduate Medical Education, and the list goes on, National Board of Medical Examiners. And currently, she just got appointed to the AAMC Administrative Council of Deans. She's a visionary and transformative leader who has facilitated the creation of our new vision here at WMed and our strategic goal to be focused on health equity. And she continues to lead the way to develop new and innovative programs at WMed. We are lucky to have her here. Her support is palpable and it's central to our work in integrating diversity, equity, and inclusion, and belonging throughout our organization and our work with you all in the community. Dr. Tamili?
Thank you, Dr. Dixon. That was really wonderful. Good morning, everyone, and welcome to our 6th Annual Health Equity Summit, and welcome to our W.E. Upjohn, MD campus of the Western Michigan University Homer Stryker MD School of Medicine, or WMed. And I want to just take a moment to acknowledge that we are located on the lands of the that were historically occupied by the Ojibwe, Odawa, and Potawatomi nations. We just want to take a moment to acknowledge and honor this ancestral land of the Three Fires Confederacy, the sacred lands of all indigenous peoples and their continued presence. I think it's very important as we talk about health equity, as we know so many in our area really have the strong desire for us to see that happen. So as Dr. Dixon mentioned, I have the privilege of serving as the Dean, President, and CEO of WMed. And our vision, recently created in a community-wide process, is one of health equity for all in Southwest Michigan through innovation in the study and practice of medicine. To us, that means that everyone in Southwest Michigan has a fair and just opportunity to attain the highest level of health. It also means that we have a job to do at WMed where we're working to create a healthcare workforce that looks and understands like the people we serve. The work around creating a fair and just opportunity for individuals to obtain the highest level of health is really what a medical school is meant to do, regardless of where you're located. However, we are the only medical school in Southwest Michigan, so it's truly our job to lead this vision and bring it to life. But of course, we can't do this in isolation. And the only way we can do it is if we serve our community and do that in partnership, so that we can have events like today where we come together for community conversations. So our Health Equity Summit is a joint collaboration among many of our higher ed institutions here in Kalamazoo. We're grateful for their support and we're grateful for their contributions. The theme of this year's Health Equity Summit is Women's Health Equity. It's a little bit by accident, and yet maybe not, that you'll see so many women leaders here today speaking about health equity. Women in the United States experience health disparities throughout their lifespans as a result of historic health inequities in the healthcare system. They face unique health concerns across their lifespan that can impact their overall health and wellness. For example, women are disproportionately impacted by Alzheimer's disease. Of the 5.8 million people in the United States that have Alzheimer's disease, 2/3 of them are women. Women account for 80% of the estimated 10 million Americans with osteoporosis and experience bone loss at a much earlier age than men. And as we were discussing at dinner last night, physiologically, men and women are different. I think that just speaks volumes right there. Caregivers are at greater risk for poor physical and mental health, and 2 out of every 3 caregivers in the United States are women. A woman is 6 times more likely to be separated or divorced soon after a diagnosis of serious illness like cancer or multiple sclerosis than if the man in the relationship is the patient. I think we should pause and think about that for a moment, knowing how challenging those kinds of situations can be for families and how disruptive they can be, and the disproportionate impact, again, on women and their health. As Dr. Dixon mentioned, I'm a surgical oncologist, and I, for many years, have specialized in breast cancer in addition to other malignancies. And I've really seen firsthand these difficult medical journeys of countless women through the years as they struggle to take care of themselves in addition to the people for whom they already provide care. So today's event features projects and presentations that involve work focused on women in the areas of clinical health care, curriculum and educational projects, community collaborations and initiatives, and quality improvement, with the overall goal of promoting health equity and women's health through our community partnerships and advocacy. Between our workshops and keynotes, we'll hear about a variety of topics, including mental health disparities, maternal immunization inequities, reproductive rights and abortion care, and others. Here today to start us off with why women aren't winning at health is not just an internationally recognized expert in this field, but also a personal friend, Dr. Marjorie Jenkins. It's really my pleasure to introduce her as our morning keynote speaker. So Dr. Jenkins serves as the Dean of the University of South Carolina School of Medicine, Greenville. She's also the Associate Provost for Health Sciences there at the University of South Carolina, and serves as the Chief Academic Officer for Prisma Health-Upstate. In 2015, Dr. Jenkins was invited to join the U.S. Food and Drug Administration's Office of Women's Health via an interprofessional agreement with Texas Tech University Health Science Center. At the FDA's Office of Women's Health, Dr. Jenkins led and disseminated research, education, and health policy initiatives across the agency and other federal and academic environments. In addition to this very unique role, she's had a number of other past important academic appointments as a tenured professor of medicine, an associate dean for women in medicine and science, the founding executive director and chief scientific officer for the Laura W. Bush Institute for Women's Health. She's also held the J. Avery Rush Endowed Chair for Excellence in Women's Health Research, and she served as the director of the Johns Hopkins Master in Education for Health Professions Graduate Student Research Program. As an academic and program innovator, Dr. Jenkins has cultivated research and education programs nationally. She led efforts to develop and implement sex and gender inclusion models and the creation of interprofessional educational resources within the U.S. medical education system. These have been adapted and utilized within numerous schools, including those at the Mayo Clinic, Brown, Rush Universities, among others. She is a tireless advocate for this curriculum. She helped launch the U.S. Sex and Gender Medical Education Summit, which has doubled in size and now attracts national and international faculty. As the founding director at the Texas Tech University Laura W. Bush Institute for Women's Health to grow and expand, she helped it grow and expand across 5 campuses and 5 professional schools. This is not inconsequential impact. This is very, very significant. And at Hopkins, she led efforts to increase capacity and align resources within the Master in Education for Health Professions capstone research program. I think it's easy to say that wherever Dr. Jenkins lands, she leaves significant impact in her wake. So nationally, Dr. Jenkins has participated in a variety of scientific positions, such as the chair of the first U.S. Sex and Gender Medical Education Summit, the expert and scientific reviewer at the NIH, the Department of Health and Human Services. She's been with the Health Resources and Services Administration, HRSA, for those of you who are familiar with that. She's even touched NASA, okay, and also for an organization I'm also familiar with, the National Board of Medical Examiners. She has served on several scientific journal editorial boards. She's delivered more than 150 presentations to professional and public audiences, and co-authored really too numerous to count works in both the scientific and public arena. Now, in case you haven't seen her in the academic realm, she also shows up in a place that I think is really important in terms of getting the word out, and that's in the public press. So she's been interviewed for Cosmopolitan, Marie Claire, Today.com. She has also served as an expert consultant for 60 Minutes for a segment on sex and gender implications on health. Dr. Jenkins has been appropriately honored with numerous awards, such as the American Medical Women's Association Elizabeth Blackwell Award, which is of special interest to us here at WMed, as we have one of our learning communities named after Dr. Blackwell. She's also received the Women's Health Congress Award for Public Policy and Advocacy in Women's Health, the Cedars-Sinai Linda Joy Pollan Advancing Women's Heart Health Leadership Award, and has been recognized multiple times as a Texas super doc for when she was located in Texas. She's truly one of the best women we could have with us here today to speak on the topic. In addition to her many, many academic accomplishments on behalf of women and on behalf of the academic medical community, Dr. Jenkins remains a dedicated clinician. She has provided personalized care to thousands of people throughout her career, and we are thrilled to have her with us here today. And with that, let us welcome my friend, Dr. Marjorie Jenkins.
Thank you, Dean Termulin, Dr. Dixon. And is Dr. Werbinski in the audience? Hey, Jan. So Jan asked me if they invite you to come to our Equity Summit in Kalamazoo, Michigan, will you come to Kalamazoo? That was 5 years ago. So I waited patiently for Kalamazoo to invite me. But the pandemic happened and, you know, I moved jobs from FDA to Greenville. And then I got the email that said, we would love to have you as the keynote. And I was really honored about that. So without further ado, I'm glad that my calendar is showing me I'm indeed where I'm supposed to be. So today I'm going to talk to you about something that I've spent the last 20 plus years of my career in uncovering. And once you hear it, I hope that you can't unhear it. And once you see it, I hope you cannot unsee it. Because we have forgotten two basic human variables that we all have without fail. And science has left it behind. And that is sex, your biology, and gender, your social construct. So my talk today is going to be about the evidence we have, the evidence we don't, and what can we do to help create health equity for women. So I have no relationships except awesome friends in the audience, like Jan. And the learning objectives are to understand the evolution of women's health and the impact of bias within the research pipeline. How do we synthesize and apply health policies and the lack of congressional mandates for equity in women's health, and know the concept of biological plausibility as scientists, and recognize how we can apply sex and gender to our clinical care. So I love this quote that this was published in 2021 from the NIH. The NIH vision of a world where every woman receives evidence-based disease prevention and treatment tailored to her unique needs, desires, and circumstances. So very quick history around the evolution of women's health. I could go back into the first suffragist movement in the 1800s, but I'm not going to do that to you. I'm not going to go through all the history of women's health. But I will say that the women's health movement, the women's rights movement, intersected with the women's health movement. And in the 1970s, when women were meeting in back rooms to look at their cervix and being taught that by a nurse practitioner, who subsequently women were arrested for doing that. And they knew nothing about their bodies, and books in the bookstore for women were about cooking and child rearing. And so women rose up and they marched and they demanded equity. And then suddenly those two movements merged, and somehow women's health really boiled down to women's reproductive rights. And so here's what we have for women's health. We have pregnancy, menstruation, hormones, menopause, the organs that we attribute to women, and the cancers and diseases associated with that. So women's health has boiled down to this. And now I'm an internist. But when I went to Texas to join the university, I had a practice, and women in the community would ask me what kind of a doctor I was. And I would say, I am a women's health doctor. And they would ask me if I could deliver their baby, or their daughter's baby, or take out their uterus. Well, they wanted to use it or lose it, and they wanted me to help them. Internists don't do that. That's OBGYN. So I decided I would just call myself a womanologist. So I am a womanologist. And people would say, well, what is that? And I would say, well, you definitely need one. So I want to talk about science. I am a recovering chemical engineer. I worked in industry for a few years. I am a dataphile. I am very evidence-based. But you know what? When we're taking care of people, our fellow humans, sometimes science doesn't have all the answers. So we have to work in that realm of the unknown and do the best we can. So sex and gender, how many in this room know that these are unique terms and what they meant? Thank you. I will not read these to you. But when I do talk about gender, I'm not talking about gender identity, although I respect that. We're talking about how your environment responds to you because of how you present yourself. I'm presenting myself as a woman. It's concordant with my sex at birth, my chromosomes, my physiology, etc. Somewhere science got lost. Now, I love science. I've done bench research, translational, clinical, medical education research. And my scientists, my basic science peers, they love their data to go down to the 5th decimal point. We love precision in that lab. And then somewhere in the 90s, we decided that sex and gender were interchangeable words. This is an applied journal of physiology, mostly cell-based and about physiology, which are sex terms, sex areas. And you can see that in the titles in the late 90s and early 2000s, we suddenly started putting gender in the title of our scientific manuscripts. Does anyone have an idea of why that might have happened in the late 90s?
You told me yesterday the 80s.
Look at Jan. I knew Jan wouldn't let me down. This was the rise of HIV. And I think people got really uncomfortable with the term sex. But we need to get more comfortable with it now because it is a scientific term. Every cell in our body has a sex. So what keeps us from finding the evidence? You may say, Marjorie, I can go and do a literature search and find sex and gender differences. Well, actually, that confusion of sex and gender means that you're going to get a hodgepodge of evidence that may or may not apply to what you need to know. So we don't have a universally accepted definition of gender. It's a social construct. What does that mean? So you need a definition. Scientists lack the knowledge of utilization of the terms of sex and gender. I had one of my scientists, a brilliant scientist, send me a paper, and she said, I want to make sure I'm using these terms correctly. And she did 80% of the time, and I was really proud of her. It's complicated. We have limitations of literature search engines. I published a validated search engine that Dr. Werbinski is going to talk with you about later. And we have no mandatory reporting of sex and gender analysis or the limitations to sex and gender analysis. So no mention of it. So these are our research environments. NIH, discovery research, right? Does anyone know the annual budget of NIH? Anyone? $50 billion. Then we get into product development. That's where I was at FDA. And then industry comes in and uses some of that discovery research from NIH to take it and expand it and bring products to market. And then we get post-market approval. And I will tell you that every one of these is done in a silo. They are not sharing information, adverse events across that pipeline. Now, I tell people as a dean, if you want to know my values, look at my budget. NIH is spending a remarkably low amount of dollars on women's health and sex differences. $50 billion, most of it not looking at what we need. So look at the research pipeline. We have cell-based, we go to animal-based, then we go to clinical trials, and then there's population health, and then we go to point of care. So everywhere along this pipeline, there's male predominance in cell-based, in animal-based. Dean Termulin mentioned Alzheimer's disease. The majority of animals used in neuroscience are male, but the majority of patients suffering from Alzheimer's are female. And then in human trials, we now have the majority of phase 3 trials have women as participants. And you might go, we've come a long way, baby, right? But absolutely not, because if you just take a bunch of women and put them in a clinical trial and you don't look at that data separately, what exactly does that do for the woman or the man? And then at point of care, we are 80% of healthcare consumerism, and we're 51% of the global population. Now, you may think that I don't love men, but I have a couple in my house that I want to be healthy as well. And one-sex gender-blind medicine impacts their health as well. When you talk about osteoporosis, 20% of men have osteoporosis. They're more likely to die at 1 year after fracture. They're markedly less likely to be sent for a bone densitometry screening. And if they are, they have to go into a breast center to get their bone density. And they do not like to do that. So there is a lot around this equity with sex and gender that impacts all of us. So reporting sex as a variable in cardiovascular studies using cultured cells. There is probably no organ that's been written and published about more than the heart in relation to sex differences, right? We have Go Red for Heart in February. So my dear colleague, Virginia Miller, and her team looked at this in 2010, and they looked again at this study in 2018. And the gray areas are where the articles that they looked at across these 16 journals did not specify cell of the sex, or sex of the cell. And then they have male in red, female in green, and both in blue. So you can see almost a decade later, we haven't moved that needle of not reporting the sex of our cells. They went a bit farther this time because we have made strides in journals requiring or having editorial rules around reporting sex. So they looked at that. Look at the yeses on the left here. Let's see if nope. Okay, so you see we have yeses over here, the total number of articles they reviewed, the percentage reporting sex, and then over here was the new study where we see that we haven't moved the needle markedly from 2010 to 2018. So it takes closing the loop. It takes having rules and regulations that we actually follow. So we have rigor and reproducibility in our science. So the lack of due diligence on the part of journal reviewers and editors to monitor the reporting of sex of cells continues. Of 16 journals, 11 had policies, and yet without reporting the sex of your cells, we can miss a fundamental understanding of regulatory physiological processes. So great science and great scientists, but do we know who those outcomes apply to? So this was a myth. So I want to bust the myth that female animals will scatter your data more than male animals. And so that was a myth propagated from the 1950s all the way through to current day, and it's absolutely incorrect. So I speak across the country, and I had a graduate student at Mayo email me an article, and she said, Dr. Jenkins, I thought of you when I saw this. It was actually studying glucose intolerance and polycystic ovarian syndrome, PCOS. Guess what they used in their animals? Men. I was shocked. I mean, you cannot make this up. Let me just say that. But we busted that myth. So male animals are as variable, can be, as female animals with the estrus cycle. So phase 1 trials. I think this is really important because we've made such great strides in phase 3 trials. But phase 1 trials, where we look at safety and adverse events in healthy subjects, we are losing the game here when it comes to including females. Anyone remember flibanserin? Flibanserin was supposed to be the female Viagra. It did not work. Trust me. You'd be hearing more about it today. But I went to FDA just as this was announced. And it's a drug for the treatment of hypoactive sexual desire disorder. Safety studies, the FDA, there were episodes of women passing out having syncope while taking this drug. So they said, we want to have a safety study looking at alcohol interaction with flibanserin because women may have a glass of wine and take this drug. Look at 18 of the 20 subjects that the company submitted back to the FDA. Does everyone see it? Raise your hand if you see it. Okay, thank you. 18 of them are men. In a medicine only for women. So I talked to FDA. I was supposed to stay a year. They kept wanting me to stay, so I stayed 4 years. I had a lot of conversations. Why aren't we mandating that we have representation of women and girls in phase 1 clinical trials? Well, the reason is Congress gives FDA the authority to do what they do. So if you want to create change, one thing is to advocate with your representatives because they can create the change and give to FDA authorization. While there, I helped lead this study, which was a 10-year review of all of the cardiovascular drugs at FDA that were approved across 5 disease processes. We looked at the prevalence of the disease and if participation of women met or exceeded the prevalence. I actually was able to look at the raw data of the clinical trials, the pivotal trials from these companies. In several large trials, we also saw the inclusion-exclusion criteria. Because here's another myth. We say women are not in clinical trials because the drug companies are writing exclusion criteria that will not allow women to participate. So here's what we saw. Pulmonary arterial hypertension is a disease predominantly of young women, middle-aged women, so we would expect that, right, to exceed, just like in an osteoporosis trial. We approached disease prevalence in AFib, but in heart failure, coronary artery disease, and acute coronary syndrome, markedly below, in the 20s and 30s. So what we found was screening did not exclude enough women to explain why women were underrepresented, and that there were pre-screening factors that probably contributed, and that the inclusion and exclusion criteria did not exclude women enough to reflect those low numbers in clinical trials. So I created this figure, and you can see you get out what you put in to a clinical trial. Women do not discontinue clinical trials more than men. We are not less likely to participate more than men. We are more likely not to be asked to participate. So there are some gendering bias going on in that preclinical setting. And so this is, how can we fix it? Well, we need to go before we actually are screening them and say, why did we pick patient A and not patient B? So here you see the same. The prevalence of the disease in cardiovascular, psychiatry, and cancer. And the blue is the participation in trials, phase 1 through 3. So again, we're not enrolling enough women that even equal the prevalence of the disease. And yet the practice of medicine is based on scientific evidence. When I was a medical student in Journal Club, we were always told you can apply this science to your population if it was studied in your population. For instance, mammography screening in a developing country may not apply to what I might look at for mammography screening in an urban city in America, in the U.S. So I wanted to look at biological plausibility, because we can't always start at the cellular level and wait 20 years to get to discovery to market for devices and drugs and therapeutics. And so here is bias very quickly in autoimmune disease. 78% of autoimmune disease sufferers are women. And yet, men are often diagnosed later with autoimmune diseases because we sexed it to females. And there's male bias in non-reproductive cancers, as you can see here. So the checkpoint inhibitors are immunotherapy treatments, and they're a game changer for cancer treatment. And yet when this group looked at a meta-analysis of checkpoint inhibitors, here's what they found. Women have increased mortality in randomized trials of immune checkpoint inhibitors as cancer treatment. Increased mortality. So by not looking at data disaggregated, not only are we missing helping women, but we are harming women. So we know that female tumors are more resistant to immunotherapies. We have increased susceptibility to autoimmune disease, and yes, adverse events with checkpoint inhibitors are developing an autoimmune disease, and women are more likely to develop autoimmune diseases. We have gender differences that cause tumor mutagenicity. So smoking behaviors in men greater than women, ultraviolet light exposure in women greater than men. All of this contributes. So you have mutagenicity biological. You have the clothing that we wear, which is gendering, which is gendered, and our behaviors around sunbathing, etc. So the bottom line is this. The biological plausibility is that we should actually be enhancing the male immune environment, and we should be enhancing tumor antigenicity in women if we're going to use checkpoint inhibitors. But we're not doing that yet. And I was working with the group that actually approved checkpoint inhibitors, and I presented this work to them just a few months before I left the FDA. And they were shocked because we do work in silos and we don't converse across environments. So what about health policy? Having gone into the federal government for 4 years, I've got to look behind the wall of regulatory science, health policy. I worked with NIH CDC as well during my time there. It was 4 of the most amazing years of my career. When we call people public servants, they really are public servants. But I also helped write health policy, and I helped review health policy. And we have an issue. So in 1977, the FDA passed a policy that women were forbidden of consenting to participate in drug trials if they were of reproductive age. Not pregnant, but you were of reproductive age. So I'm a woman, I'm of reproductive age, and I want to participate in a drug trial because I have a certain disease. The FDA said you can't because they were protecting us. Because those pesky hormones somehow frink with our brain and we can't give consent. That's a joke. I need some laughter going on. Yeah. Okay, thanks. So then we move forward. And they overturned that mandate in 93 at FDA. We had the Office of Women's Health come into play. All of the CDC, HRSA, HHS created offices of women's health. For the one at FDA, the FDA commissioner at the time announced to his senior leadership, we are going to sunset this office in 1 year because we will have fixed this problem. Really? Okay. Well, he was bold. I want to point out the FDA clinical hold rule in 2000. The clinical hold rule says the FDA can put a study on hold if women or men are not allowed to participate due to reproductive issues. How many times do you think the FDA has put something on hold? 0. Jan, they're going to think you're a plant.
You didn't tell me that one.
No, I didn't. You know it. So in 2001, the auditing office, GAO, in the federal government came to FDA and reviewed their participation of women in drugs. And they found that 8 out of 10 drugs that had been pulled from the market in the previous 10 years were more detrimental to women. 5 of those prolonged the QT interval and caused torsade de pointes. Now, you probably also know that women have a longer QT interval, and women are more likely to take medications that prolong the QT interval, like antihistamines, antibiotics. So when you put all of that together, and then you put a woman on one of these medications, you can promote a fatal arrhythmia, and that's what we saw. So 8 out of 10 drugs. And then we looked at the NIH policy of both sexes. Sex as a biological variable came out in 2016, and I was joyous. We were, right? We were like, wow, we made it. A trans NIH policy mandating the study of both sexes, and here's how that looked. So in 2015, right before that policy was implemented, the GAO came over and audited the NIH. They found out that 56% of women in clinical subjects in clinical trials were women. But that the NIH did not track whether the study included plans for analysis by sex. They lacked summary data to identify potential sex differences, and it limited assurance that NIH is supporting research that can inform medical care for both men and women. Would you be surprised to know that I have an exact same slide from a 1990 GAO audit of NIH, and I have the exact same slide of a 2020 GAO audit from NIH? Almost exact wording. And although I love this policy, and I'm a big fan of Dr. Janine Clayton at the Office of Research in Women's Health, this policy has no teeth to it, which means I am not required to report my findings of sex differences, even though I have to have a plan for studying both sexes. So basically, it's kind of like a Congresswoman once said, I'm going out to go grocery shopping, and I tell my teenager, when the washing machine stops, put the clothes in the dryer. And I come back, and the clothes are in the dryer. I open the door, and guess what I find? Sopping wet clothes. And so you go, I asked you to put the laundry in the dryer. And yeah, but you didn't tell me to turn it on. Hello. So we've been pushing and pushing and pushing numbers of women in clinical trials. We need more women. We need more women. And women have stepped up to the plate. And yet we are wasting the opportunity to look at that data. So when I give a woman informed consent for a clinical trial, and I say, this may not help you, but it will help women like you or people like you, is that really true? Most of the time, the answer is no. We don't know. So more women participating in research, but we don't have market progression in reporting outcomes. And I think FDA and NIH and health policy should stop with the might and may and could and should and expected to. Because, you know, when I tell my teenager to clean their room, you might want to clean your room before you go out with your friends. They're walking out the door. See you later, Mom. I go into their room. Do you think I find it spick and span? No, because I gave them an opportunity to not do it. Health policy is rife with these words. We need more action verbs, mandates. $50 billion. If you don't do it, you don't get funded. That is a pretty easy thing to look at. So I want to just talk briefly, and I know you have some discussions later around pregnant women and lactating women. I was the commissioner's proxy to a congressionally mandated task force around research in pregnant women and lactating women. And on the first meeting, all-day meeting, we met every quarter for a year, and then we gave a big report with 12 recommendations to the HHS secretary. And at the first meeting, I'm not sure why the commissioner selected me, maybe because I was more of an outsider to FDA, and I'm not an OB-GYN or a pediatrician, I'm an internist. But I knew to bring expertise to the task force from the agency, so maybe that's why he selected me. But there were stakeholders and big pharma and every office in the federal government at the table, and I was an unknown to the stakeholders. And so they wanted to know in the labels, do you guys know that we don't use A, B, C, D, X in drug labels anymore? That was gone away in many years ago. And they have a new labeling rule that in Section 8, it tells you what research is available for that population, pregnant women and lactating women. So I made a commitment that I would review the drugs that had changed their label over to date and bring that report back to the task force. So I went to the FDA to get the data. They didn't want to give me the data. So the stakeholders went to a senator, Senator Collins, and she wrote a letter demanding the data. So then we had to do the audit. And I say this because when we look at drug interactions of diseases that women have while pregnant, so women still have epilepsy, asthma, high blood pressure, they get infections during pregnancy. And we know that hormones interact with concentrations just as in these atypical epileptic drugs. So I tried to get the data. The first meeting, I promised it. The second meeting, didn't have the data. Third quarter, no data. Last meeting, I told the FDA, I said, I need this data. I need it cleared. And clearing can take months. But we've been waiting for months. So we had to vote on the recommendations to go to the HHS secretary. And I was voting for the entire FDA. If I said no to something, pharma followed me. So suffice it to say, I was getting texted from the C-suite of the FDA. I was like, okay, we're going to say no to this. No, we're going to do that. So it was a big deal. And it was a lot of pressure for everyone at the table to really make consistent recommendations to try to change the landscape for pregnant and lactating women. So I got the approval to release the data. You want to know what time I got the? 1 o'clock. We adjourned at 1 o'clock. So task force wrapped up. Recommendations were made. This data isn't going in the task force report. They did not know me very well because I had made friends with the head of the task force from NIH and their office, and we had worked together the year. And I went over and I said, I have this vetted, approved, cleared FDA data. I would like to put it in an appendix in the report. Could we do an email vote? And I'll write the verbiage around it. And that's all I'm asking. If they say no, it's no. Because here's what we found, 575 drugs, and just go right to that last red sentence. 72% of the products had no human data. None. So we had patients come in and talk to the task force. We had a day of multiple sclerosis. We had a woman who stopped her drugs because she wanted to get pregnant. She had lost a pregnancy. She really wanted to get pregnant. So against her doctor's wishes, she stopped her drugs because they didn't really know what they would do to the fetus. So she had rapidly relapsing MS. She was never able to walk again. That's one in literally hundreds of thousands of things that happen across the U.S. and the globe every day because we are protecting women from research instead of protecting women with research. So I just put this one slide in about AI because I talk to ChatGPT all the time now. It writes poetry for me. Write me something that tells me how great I am. Yeah. But I had someone say to me, well, artificial intelligence is going to take care of the bias. I'm like, what? Do you know where ChatGPT gets its information? From real world data. So I say bad data in, bad data out. That's what we're going to get. So last I'm going to talk to you about implicit bias and the gendering. So we know there's sex differences, metabolism, sex of cells. We've talked about anatomy, physiology, etc. But what about just implicit bias, the hidden agenda we're teaching in our medical schools as well when we say 70-kilo male is the norm? So Cleveland Clinic is a top cardiovascular center. They perform this study in their emergency room of diagnosed ST elevation MIs. So diagnosed heart attacks in men and women. You see the numbers there. Who received the level 1 standard of care guidelines? 77% of men and 69% of women. Who got to the cath lab faster? Men, 104 minutes, women, 112. And then the 30-day mortality was 6.1% higher in women. So Cleveland Clinic said, we've got a problem, and they implemented a very straightforward 4-stage algorithm. Every triage nurse, every physician had to go through this protocol, and they redid their study. So you can see on the top is what I just spoke with you about, the numbers, but look at the bottom after the protocol. Men and women were close to equal, and there wasn't a statistically significant difference between them any longer, and we lowered the mortality of women by almost half. But do you was this a biological difference, do you think, that women were dying at higher rates in the first study? It was gender bias. For some reason, we weren't offering women level 1 standard of care with the same exact diagnosis. So what was left, this 3% plus between the males and females, that bottom line right here, that's biology. So when you stack gender bias and biological differences, bad things can happen. We've seen it in patient-physician concordance, that women in the ER, women physicians taking care of women patients, women are more likely triaged to being worked up for a heart attack. For if I go in and I think I'm having a heart attack and I'm anxious and I'm like, oh my gosh, I think I'm having a heart attack, my jaw's hurting, and I heard it on an American Heart Association commercial that this means I'm having a heart attack. And they take me in, they put me in a room, and one of the first questions I promise you that the provider will ask me is, are you stressed? And I've just started saying back to people that ask me that, are you stressed? Are you transferring to me? Because if any doctor ever asks you, are you stressed? Don't say it. Just say, are you stressed, and move on. So basically, we saw that with concordance that women were more likely to be diagnosed earlier. And that is no fault of the provider standing there in the emergency room. That is the hidden agenda we have taught them in medical school and residency. So that is fully on the educators. And I put myself in that. So women bear a disproportionate burden of the systematic failure to advance the knowledge and clinical application of sex and gender differences. Women are bearing our systematic failure. We are 30 years into talking about sex and gender differences, and I told Dr. Werbinski I was hoping I would be put out of business by now. But we're not there yet. We've got a long way to go. So healthcare is a customer service industry. You may wonder why I'm showing you a dry cleaner, a veterinarian, a mechanic, at a restaurant. Any thoughts? Because if you get bad service at any one of these, you're going to go find a new dry cleaner. You're going to not go to your vet if their front staff are rude, which I've changed that. If they messed up one of my dresses, I don't go back there. If the mechanic blows me off 3 times and my car's still making the noise, I'm going to go to somebody else. And if I get bad food or bad service at a restaurant, I'm less likely to go back there. And yet, we don't advocate for ourselves in the healthcare industry, which is a customer service industry. You have choices. Anybody heard of medical gaslighting? I mean, come on. This is nothing. You're stressed out. Like, it's not your head. You don't have a tumor in your head. You have irritable bowel syndrome. You don't need a colonoscopy. It's just your stress and your diet. Google it. You will find story upon story upon story of late-stage cancer diagnoses, brain tumors, and tens of thousands of women are detrimentally impacted by medical gaslighting every year. So we have to empower our women. But if the healthcare doesn't listen to women, women will seek, where do women seek help? Google, Dr. Google. So we have the predatory wellness industry. $4.4 trillion. The majority of users of the wellness industry, women. They get us at our lowest point. We need to detox. We're going through menopause. We're gaining weight. We just had a baby. We have fatigue. Our sex drive is low. So you have detoxing super powder, morning skin super powder, and the mother load with that handful of pills that you're supposed to be taking because pregnancy has sapped you. And they cost money. So this is predatory for women and not only giving them hope, but taking their money. And most of the time there is no evidence around these things, proprietary blends. So last but not least, how can we change this for our providers, our future providers? We have an R25 grant at our School of Medicine from the NIH to teach sex and gender and implement and integrate it into the curriculum. We have to teach our faculty first what sex and gender medicine is and evidence in order for them to pass it to the students. And these are the 2 books that were available in 2004 when I entered my career path into this area. The Principles of Gender-Specific Medicine by Marianne Legato was an 889-page tome that I put on my bedside table, and I read it cover to cover in a year. I told you I was a nerd. So that's my bedtime reading. It was dense, really dense. This is Exploring the Biological Contributions to Human Health, Does Sex Matter? 2001 Institute of Medicine. And so it took from 2004 to 2020 for us to put this book together, which was How Does Sex and Gender Impact Clinical Practice? This is not a lot of dense, heavy science. It's case-based. It has practice points you can take back today to your practice to change the implicit gender bias and provide the proper and optimal treatment for all of your patients, not just women. And so this was really a labor of love for me to be able to work with Dr. Newman and 20 plus co-authors of the chapters to create that book. But we now have enough evidence. Why do I say that? Because we have clinically meaningful evidence. I know the differences in how your hair grows to bunions. I know sex differences. I eat it for breakfast. I'm really chatty at cocktail parties because I can say, do you know why men never remember and women never forget? And they're like, no, tell us. I go, we don't know yet. Science is just, that's how it is. And students want to know this. This was a study in 2015, a national study. Knowing sex and gender medicine improves one's ability to manage patients, 96%. Medical education should include teaching of sex and gender. And so we're redoing this study now with the work with Dr. Werbinski's group and AMWA. We're redoing this national study to see if we've moved the needle. But our new learners, the millennials, the Gen Zers, the zillennials, they are a very societally aware generations. And so I'm really hoping that we've done more to move that perception. And talking about equity, I'm so glad that we've moved away from equality, right? Equal really is in a math equation. It's what blue stuff I put in my coffee. Or people will say, well, you should be fair. Well, fair is what I pay to get on the airplane today. So I don't want fairness. I want equity. And when we talk about intersectionality of social determinants of health, Black women are the least likely to be included in studies, in scientific studies. But intersectionality makes biological scientists sort of blur over. It's a social construct. So if we put the social determinants of health, low SES, first gen, rurality, and race ethnicity, and then you start stacking it with all of the bias throughout the entire patient encounter. I don't communicate well. Women are interrupted on average 11 seconds into talking about their chief complaint. 11 seconds. Physical exam, labs and diagnostics that are using male norm data to set the range for females, and then the therapeutics that haven't been studied or the data hasn't been disaggregated to look at safety and efficacy. Think about the stacking and the inequity that just grows and grows and grows. If you see patients, you can stop this. You can help this. If you are a scientist, help us to not do this. We need answers. So here's how I think health equity can be achieved. I've already said all of this during this, and you can read it faster than I can read it to you. But these are real issues. They're causing inequity across our populations and have been doing so for hundreds of years. And so now, I hope that you really can't unhear what I said. You don't have to remember all my jokes. And that you can't unsee. And when you review a manuscript, when you write a manuscript, when you're looking at applying a new clinical guideline to your patients, that you actually think about, have we looked at the biological differences? And is there gender implicit bias in this space? So thank you very much.
So knowing that, I mean, given the lack of information that we have related to the sex differences, like in labs or even in outcomes, it feels as if we have an opportunity to leverage the electronic health record.
I love that. We are at our medical school. Our medical school is about the same age as Stryker, and we are building a health research biohub because our healthcare provider, our partner Prisma Health, has epic data across 2/3 of one of the unhealthiest states in the country. So we are going to utilize that data to create a queryable research database of a very diverse populations. And the issue around that is some use Epic, some use Cerner, so, and you cannot marry those data fields very easily. So it would take pulling that data out of Epic and Cerner and getting it into a database that you can query that's de-identified and scrubbed, et cetera, data. But absolutely, the technology that we have today should make uncovering these issues and help us develop hypotheses to answer those questions. Drive hypothesis. That's what we need the data to help us do. Any other questions?
But again, it's data in, data out. We have to put in the right data into the electronic record.
Exactly. We do. So, Nothing else?
I don't have a question. I just have instruction. I know lots of people assume they have a loud voice, so they don't use a microphone. You don't use a microphone to amplify the volume of your voice. You use it to amplify tones. So people in the audience who have hearing impairments, whether it's a low tone or high tone, that's why you use the microphone. So do not be one of those folks to say, well, I speak loud. Well, good for you. We still can't hear you.
I hope I did okay today. But you're right. Yes. You're right. Yeah. Inclusivity matters. 2 questions back there.
You mentioned that it is required that they have different sexes done in their studies. It's just not reported. Has there ever been a mandate saying, go back, look at your data, separate it out, and report to us the differences because they have the raw data?
Yeah, I would love that mandate to come out. It is not there yet. Now, they are encouraged, and I do want to give a shout out to the Office of Research on Women's Health, who over 30 years has gotten us where we are today, to even say, if you have a disease you're studying and it's in both males and females, your animals and even your human studies need to enroll both sexes. But it's really on the part of the journals, right? I just showed you. They have editorial policies. They're not enforcing them. And so who here thinks that post hoc analysis is data mining? Post hoc analysis is data mining. Anybody? So that's actually what we hear from some of the higher impact journals. You can't do post hoc analysis. Well, guess what? Post hoc analysis gives us a signal to help develop our next hypothesis. But now you've made it a bad word, so we don't want to say it. So basically we have just historical layers of, I think, a little bit of pompousness and arrogance on the part of our scientific environment that is keeping us from making these mandates with teeth to them. The carrot is the millions of dollars you get in your study if you're funded, but the stick is that you really have to separate your data and look at it. Any other questions? We're good. I want to keep you guys on time.
I just wanted to ask if you were familiar with other countries like Canada or the EU. Do they have different regulations for their similar organizations that require that gender, sex reporting?
Yeah, so Canada and the EU are farther advanced in that area. And Dr. Werbinski's probably just even been to the EU or Canada. She wants that mic, so I'm going to let her, if you'll bring it over, Laura, to Dr. Werbinski. Thank you, Jan. Because she lives in this world.
At AMWA, at the annual meeting last year, or 2 years ago, we did a panel discussion of women physicians from 5 different countries and how they approach sex and gender difference, healthcare delivery and education. We didn't go down to the level of research. But in Brazil and Italy, they actually have laws that say they have to teach sex differences in their medical schools. And Canada they haven't made it a law, but right. Canada is way, way ahead of us. Yeah. And also the Scandinavian countries who have such great databases because they have universal health care, they're all way ahead of us in this. We need to catch up.
So you can look at the countries like Germany who do the EU has had many discussions and supports this work. And we have Charité, the Women, Sex and Gender Institute in Berlin. We have Karolinska, has a Center for Women's Health and Gender as well. And so we have a lot of global women's health and gender scientific institutes at very prestigious universities. And here in the U.S., Stanford, Yale, et cetera. And the issue is that we're hesitant to create policies and regulations and funding mechanisms that make the scientist or the investigator even say, yes, I tried to recruit enough women. However, I didn't get there. But when I look at the data, it's not powered, but I am seeing a signal that's concerning. So here, can you give me a supplement, NIH, to continue to enroll women? And how about the Physicians' Health Study, right? 100,000 physicians boiled down to 22,000, followed for years for heart disease. Male. So we know that. So how about a women's physician's heart study? You don't have to reinvent the wheel, but if you haven't studied something in that population, then look at it in that population. So I think people are trying to make this too narrow of a box, when really you can go all the way to the clinic and get biological plausibility and move back to the bench, or you can go from the bench and move forward across to point of care. There's no rules against going backward or going forward.
I really enjoyed the presentation. And at the beginning you said, sometimes I don't know why it's true that people are scared to differentiate sex and gender. Like the word sex is already kind of like, I don't know, a bad word. And I noticed that sometimes what students are learning is also like, I think they are scared to notice that sex is something that is biological. So I don't know, sometimes when they study anatomy, they don't want to say female anatomy and male anatomy. They're just calling, we are studying anatomy 1, anatomy 2. It's like,
wow.
So it's like, yeah, this is male anatomy, this is female anatomy, then gender is another thing. But I think med students need to recognize that and value those differences. So then when they take it, they also, I don't know, they understand that difference and is better. But I'm seeing that the students don't want to recognize those differences, and sometimes in the education is not well explained, you know what I mean?
Absolutely. And I think we as educators can empower them to say sex as a biological variable is something that each and every one of your patients will have without fail that can impact their health outcomes. You want to be the best physician you can be? Know the sex differences. And it's not gender. It's not social construct. That's another area that you will need to learn about. But we have to take away the hidden agenda of medical education and actually bring this to the forefront. And even if we don't have the data in women, the lecturer should say this study, this pivotal trial, was done in the majority of men. And not only that, mostly white men. So it just compounds, but we at least need to say it out loud instead of just saying, oh, this study shows this for prognosis in this disease. And basically, everybody goes, oh, that applies to everybody with the disease. So we need to say the words out loud, I think, as educators and tell them to utilize them correctly. I'm very polite when a student or a resident wants to come and talk to me about sex and gender, and they'll tell me a story they saw in clinic, and they will be using the wrong terminology. And I will just really gently say, so when we're talking about anatomy or physiology, then let's talk about males and females. But if we're talking about epidemiology or presentation, let's talk about men and women, boys and girls. That's just the terminology that'll keep it straight for you. Question? And I think this will be the last one we can take.
So, for the issue regarding the differences between sex and gender, do you think that just starts earlier and earlier in childhood as we go through the years? Like, where do you think that bad word of sex kind of begins and how that develops as they come into college and school and further on?
Yeah. Well, I think that from probably K through 12, when we hear about sex, it's about sex, like copulating. And so that's a bad word in many areas, depending on the state and the region you live in. And I think that we need to start, when we talk about biology, when we're taking biology in our middle school, in our high schools, start there. Talking about sex is a biological variable. And yes, they'll giggle and they'll get, a little embarrassed. But let's take away the taboo of that 3-letter word and make it about science and about human health and move that through. So I think it should actually begin in about 4th grade or 5th grade. All right, you guys have been an amazing audience. This has been a joy to talk about something that I just truly believe in and am passionate about. I thank you for your attention and your time. Again, to the planning committee, appreciate the invitation. And I hope you have a great rest of your day.
This thing on? Oh, good morning. One more round of applause for Dr. Jenkins, please. I get the pleasure of releasing you folks to the break, so please get some snacks in the back. And as you find your way throughout our hallways this morning, you got about 15 minutes. The workshop session starts at 11. If you have your booklets in front of you, that's going to be on the second page, technically. I'm also being told and directed to make sure you folks take a gander through the bookstore, as well as the poster showcase, which is going to be on the 2nd floor. So you got about 15 minutes. Use the restrooms and enjoy your sessions. We'll be back here for lunch starting at 12:30. And have a good morning. Thank you.
Could you announce that the first 40 people can get a signed copy?
The first 40 people get a signed copy of Dr. Jenkins' book. Did everyone hear that? The first 40 people get a signed copy. So, am I exempt from that? It's free. And it's free. It's free. That's like free. Okay.